Okay, good morning, everyone. Just thought I'd introduce Sofiane Ouerd. He is our cardiology resident, a C1. He comes from Quebec. He did med school at University of Montreal and undergrad at McGill, and he's today is going to be talking to us about pericardial effusions.
Thank you. So, basically today's talk is going to be about echocardiographic evaluation of pericardial effusions. My name's I'm first year cardiology resident. So the reason I chose this topic is now it's been 4 months of training, and I've already had like numerous consults about pericardial effusions. You know, there's a big effusion. Is this tamponade? Do we have to do a pericardiocentesis? So I thought it was quite relevant of a topic. And it kind of begs this philosophical question of to tap or not to tap the effusion. And so I thought it'd be a useful reminder for the trainees and also all the staff. Okay, so learning objectives today. So reviewing the physiology and clinical features of tamponade, and that's quite useful as well before going into the echocardiographic features, I think, because that allows us to understand what we're doing. And then discussing the sonographic features of cardiac tamponade. And then lastly, kind of going a little bit briefly over the role of echo in guiding pericardiocentesis and how that's helped us. So let's start with the clinical case here. So we've got a 23-year-old man with malaise chest pain. So when you get a bit more history, it sounds like it's been a grumbling low-grade fever, bit of malaise, fatigue for about 2 weeks, followed by onset of pleuritic chest pain, worse when supine, gets better when they stand up, no exertional component. They're otherwise healthy, no past medical history, no medications, no allergies. Blood work's normal, no troponin elevation or anything. ECG shows pretty diffuse ST elevations, consistent with acute pericarditis. And then the bedside echo by the emergency physician's normal. So they discharged the patient home on NSAIDs, colchicine. The patient feels a bit better at the beginning. Unfortunately, they come back to the emerge shortly after, 3 weeks later, with recurrence of malaise, now dyspnea, orthopnea. They're not feeling well. So on exam, I think we can all appreciate a sort of a depiction of what the patient might look like. It looks very uncomfortable, unwell. BP is 93/69, narrow pulse pressure. Got a pulse of 110, 96% on room air. GVP is elevated, as you can appreciate. Distant heart sounds with no pericardial rub. And there's 1+ pitting edema to the shins bilaterally. And so here you've got the 12-lead ECG. Maybe one of the fellows can kind of tackle it. You don't have to go into sort of, axis and all this stuff. Just what's the striking feature here that we sort of see on the ECG?
Sinus tachycardia, some diffuse very, very, very simple. Otherwise, we can see the alternance of the QRS vaulting.
Yeah, exactly. So this is the point here is here on the V1 lead strip, you can kind of see this electrical alternance. So you've got the QRS axis, which sort of changes during the strip, which kind of points to potentially a large pericardial effusion where the heart is swinging around and sort of changing the axis. And so this obviously prompts an urgent echo. And so cardiologist consult in, then you go see the patient, and this is sort of what you see on the echo. So I think that, you don't have to be level 2 sonographer to see that this is bad. So you've got a subcostal view here of the heart, large pericardial, very large pericardial effusion here. A lot of different features here that are abnormal. But I sort of started with a very abnormal echo so that we can sort of discuss afterwards more subtle findings. Unfortunately, in real life, it's more subtle than this. Well, fortunately for the patients. But this is sort of features of cardiac tamponade. So let's talk first now a little bit about the physiology and clinical features of cardiac tamponade. So starting with the anatomy of the pericardium. So here on this pictogram on the right-hand side, you've got the myocardium, with the endocardium layer inside. The pericardium itself is sort of, there's first an inner double-layered serosal membrane. So the parietal or the visceral pericardium is attached to the epicardium and the epicardial fat. And then on the outer edge, you've got it attached to the fibrous pericardium. It's a bit more of a stiff structure, provides some protection. And in between, you've got under normal physiological conditions up to 50 milliliters of fluid. And that fluid is drained by the lymphatics in the pericardiocentesis veins. So when assessing pericardial effusion, so what's an effusion? Really any abnormal accumulation of fluid within that pericardial space. There's various causes. Typically, acute pericarditis is a cause for which there are also numerous etiologies. Often it's idiopathic because we're not able to find a cause. Infections are still a very large cause of them. So viral infections, in developing countries, TB is still a fairly common cause. You've got immune causes, things like connective tissue disease, lupus. Malignancy is still very prevalent. And then you have to think about, other things like post-cardiac surgery, post-trauma, and those are important because they can also cause different types of loculated effusion, so that's something to consider from the history. So when assessing effusion, you kind of want to look, is it circumferential or is it loculated? Is it transudative, exudative? You can look for things like fibrin strands, or there's heterogeneity within the pericardium that might point to some blood. And then obviously you want to assess the size and diastole. And the importance here is this is where echo is very useful because CT often is not gated, and so you can overestimate the size. And so here, small is less than 1 centimeter. This is for ASC guidelines. Moderate 1 to 2 centimeters. Large is more than 2. Very large more than 2.5. And sort of the estimate of that volume here that I found was about less than 100 cc for a small one. A large, you can see you can get more than 500. And then this is sort of depiction here. You've got a subcostal view of circumferential pericardial effusion that's quite large. And that's sort of referring to this anechoic space here around the heart. So it wouldn't be an echo talk without kind of talking about the views here. When assessing pericardial effusion, you still want to go through your regular views. On the top left here, you've got the peristernal lung axis. An important thing that I just want to bring up here is that, as a reference, so when you're trying to differentiate between a pericardial effusion and a pleural effusion, often it's useful to use the descending aorta as sort of a landmark. And so anything that connects anteriorly to it, speaks to a pericardial effusion, or if it's deeper, then you've got a pleural effusion. Sometimes it can both be concomitantly present. And then, you also can look at your peristernal short axis here, kind of looking at possibly some fibrin strand around, possibly. And then the apical 4, and you've got your subside 4. And these are all important to get because this was also, as I'll talk later, when you're looking at the potential for pericardial synthesis, then you kind of want to look at which view is the most amenable to a percutaneous approach. And then one last thing I'll mention is that it's important when doing this study to also use a respirometer, because we're going to talk about sort of the respiratory variations of a lot of the pericardial physiology, and so that's quite important when doing a study. So let's talk a bit about the pericardial physiology, because I think that'll be quite important as well, and some important points here. So this is adapted from an old publication by David Spodek in New England in 2003, looking at sort of that physiology. So you've got a pressure volume curve here. On the y-axis, you've got the pressure in the pericardium. Then the x-axis is the volume. And so as you increase the volume within that pericardium, I think you'll appreciate, that pressure is going to eventually increase. And then here you've got two curves, sort of, one is a rapid effusion, so very rapidly growing, and the other is a slow effusion. And as you can appreciate, as that volume goes up, if it goes up too rapidly, that pressure will quickly rise. Whereas if you've got a slow growing effusion, you've got time for the pericardium to stretch, accommodate, it becomes more compliant, so it's able to accommodate much higher volumes. And then here on the dotted line, you've got sort of the limit of pericardial stretch, beyond which, if a pressure exceeds this, then you start getting into sort of tamponade physiology, by which I mean, you've got chamber collapse, you've got hemodynamic compromise, you're limiting cardiac output. And I think we can all see that, for a rapid effusion, it doesn't take as much volume for it to really reach that pressure sort of limit here. Whereas if you've got a slow growing effusion, you can accommodate a lot more before you reach that. That's important because a lot of people can, see an effusion. If it's small, they may not think that it's tamponade, but really the volume is in a clinical context as well. So I just wanted to mention that because that's important. And the other piece of pericardial physiology that I think is important to mention is this concept of ventricular interdependence. So, you've got the right ventricle and the left ventricle separated by the interventricular septum. And as you take a breath, so you're lowering your diaphragm, you're generating negative pleural pressure, and so that creates almost a bit of a vacuum for which, as you know, the heart sits in the chest wall inside the thorax, and so that increases venous return. The RV gets a bit bigger, and under normal circumstances, you do get a little bit of intraventricular shift. For which the LV then is a bit of its total volume cardiac output. And so this is all physiological. And so on inspiration, you do get a bit of a drop in blood pressure. That's normal. And then it rises on expiration as the pleural pressure becomes more positive, the LV is able to expand, and then you get that. And so what we're talking here is less than 10 millimeters of mercury in the respiratory variation. And this will be important later when we talk about pulsus paradoxus, which is an exaggerated response to this physiological phenomenon by virtue of the fact that now there's a pericardial effusion around limiting the expansion of that LV when you get the RV increase. So what is tamponade? So this is taken from the ASC. So it's an abnormal accumulation of fluid or blood or both in the pericardial space. So that's an effusion that both compresses the chambers and inhibits their filling, leading to varying degrees of decreased cardiac output. And so it's quite heterogeneous in terms of what the presentation might be. It's a clinical diagnosis, but assessment of the patient's condition and diagnosis of the underlying cause of tamponade can be obtained through lab studies, ECGs, echo, or other modalities. And so echo has really become sort of an invaluable modality to use in assessing for tamponade. So it wouldn't be a talk about pericardial effusion if I didn't mention Beck's triad, and I know Dr. Chow loves some of the historical components of medicine. So this is Claude Beck here on the left side. He's a famous French cardiac surgeon. So he published this in JAMA in 1935. So this is an article here, sort of proposing two cardiac compression triads, the most famous one being the sort of acute compression triad. Whereby here on the this is actually published inside the article where he talks about three different things. So low arterial pressure, so sort of shown here, as we know, if you limit cardiac output, then you get that. High venous pressure, so here there's a manometer showing 10 centimeters of water, so elevation. So clinically we see that in sort of distended neck veins, elevated JVP. And muffled heart sounds, which is listed as quite heart. So, back then when you didn't have the advent of echocardiography, this was quite useful. But as we know now, clinically, probably about 1/3 of patients in reality have all three. And so it's not the most useful to use, to be able to rule out tamponade, but still historically interesting. So nowadays, what do we have then for clinical features of cardiac tamponade? So the clinical features will really depend, as I mentioned, on its variable depending on the speed of accumulation of the effusion, such that acute effusions from an aortic dissection will lead to a patient being much more sick than a chronically growing effusion. But some of the things: tachycardia, dyspnea, tachypnea, hypotension, chest pain, orthopnea, pulsus paradoxus, which I'll talk about in the next slide. And then, whenever this is sort of taken from the JAMA Rational Clinical Exam Series, does this patient have cardiac tamponade? Where they kind of look at all of the different things that we have and sort of check for sensitivity specificities. And I've recently written my Royal College exam, so they love kind of testing on these things. So I thought it'd be interesting to kind of look at them. So here on the bottom right, you've got the sort of the symptoms that we looked at. So dyspnea seems to be pretty good in terms of sensitivity at 88%. So it's useful. Tachycardia, when you do a pooled sensitivity, 77% of them are tachycardic, but as we know, very non-specific. Hypotension, if you look at it, really 26% pooled sensitivity. So if you're really relying on hypotension to guide cardiac tamponade, you've kind of missed the boat most likely. And then tachypnea I thought was interesting, is also 80%. So if you're looking at these things, it sort of helps. And then pulsus paradoxus, when you look at the sensitivity, it's quite good. Pretty high, and then here it's not the most specific because other things can cause it, asthma, COPD exacerbations. But if you increase the amount of difference, that is on inspiration, a drop in blood pressure, then you do kind of increase the specificity, and that's where that 10 to 12 kind of comes on assessment. So what is pulse paradoxis? Well, as I mentioned, normally under physiological circumstances, you do get that ventricular interdependence. You get a drop in blood pressure on inspiration. So really, it's just a more pronounced normal physiology of increased interdependence, where the drop is greater than 10 millimeters mercury. So how do you check for that? So here, looking at if you've got, let's say, invasive monitoring of your arterial waveform by virtue of like an arterial line, you've got that drop that you can see in real time in inspiration, where all of the systolic kind of drops here, and that gets higher on expiration. There are other ways to measure it. You can do this by virtue of using, a manual sphygmomanometer, but I'll sort of spare you guys the protocol for that. And then here, explaining what that is again. Once again, you've got this kind of box here. The heart increased inspiration, you get increased venous return. The RRA and RV get bigger. It's a bit of bulging. The LV is not able to accommodate. And then here under tamponade, basically that effusion is limiting the outward expansion of the LV, and so that leads to greater swings in blood pressure drop during the respiratory cycle. Okay, so that's enough about like sort of clinical features of all this. Now let's kind of talk about the echocardiographic features of cardiac tamponade. So looking at the ASC, there are a lot of things that you can find, some more subtle, some more prominent in tamponade, but these are the big ones that I don't think I can go over, and I'll kind of tackle them one by one on different slides. But broadly speaking, we're going to talk about sort of chamber collapse features, the IVC assessments. So these are like 2D and M mode assessments. And then Doppler, so we're looking at things that show signs of increased ventricular interdependence. And then as well looking at Doppler and the hepatic vein and looking sort of flow reversal. And certainly swinging of the heart in the pericardial sac is never a good thing. So that sort of also present there. Okay, so looking at right atrial collapse. So when we talk about chamber collapse, we want to look at it whenever that chamber is in its smallest filling pressure. And so usually that's in diastole. So here for the right atrium, a lot of studies show that in late ventricular diastole, you start to get the atrial relaxes, and then you're able to sort of get a bit of collapse because of the fact that the pressures are smaller. So there's a question here: is the RA collapse in diastole? So what I found with late diastole, certainly RA systolic, like a ventricular systole that is atrial diastole is what you might intuitively think, but from one of the studies I've seen is that they really comment on late diastole, ventricular diastole. So looking at the RA collapse, it often precedes clinical signs. So this is a very specific sign, but not often, very sensitive, but not often very specific. Because you can get transient buckling of the RA, and that can be seen without tamponade. What increases the specificity of it is really making sure that the collapse happens in more than 1/3 of the cardiac cycle. And when you do that, it reaches near 100% specificity. So that's something important. And then sort of here are the parameters you're looking at, sort of how does it perform. So again, like I said, more sensitive than specific, but a big range here. What we're looking at here is a collapse here. I don't know if they're able to see my cursor, but kind of see it more on the 4-chamber view here, where you get a bit of that buckling inside by virtue of the fact that the effusion is sort of compressing on that chamber. Okay, so now if we look at RV collapse, so here again, we're talking about sort of when that happens, when the chamber is at its lower state of filling pressures. So diastolic RV collapse is another feature. This is a little more specific, but less sensitive than RA collapse. But certainly important to look at. And so here again, this is parasternal long axis, and so you see a sort of anterior pericardial fusion kind of bulging in on the anterior wall, and then it's hard to see here in real time, but if you slowed it down with ECG strips, and you might be able to see that this is during diastole. So something that's helpful to be able to look at that is really to run an M mode through it, and then what you're seeing here is that you're going to get that RVOT dropped here. So during diastole, the mitral valve opens, so you're able to sort of gate it there to see, and then that's quite useful to be able to assess in real time with a bit more precision there. And so kind of going back to what I said, so this is, usually it's actually early diastole when the RV pressures are at their nadir. So that's when you can catch it the most, but certainly as a collapse worsens and you get it more throughout the cardiac cycle, that's usually a bad sign that kind of correlates to worsening hemodynamics. There is actually some respiratory variability as well with the collapse. So as I mentioned, during inspiration, you get a sort of almost an increased venous return, a bit of a bolus, and so the collapse is lesser. So if you actually ran this through inspiration and expiration, you'll see that there's a bit of variability such that the collapse is worse during expiration than inspiration here on M mode. Here you see a bit more of that kind of collapse. It's more prominent. And you can even see that the LV actually gets a bit smaller as well during the collapse. So the next thing to look at IVC plethora, and what I mean by that, and sort of this is the parameter that's been suggested, is a dilated IVC more than 2.1 centimeter with less than 50% respiratory variability. And that's been shown to be quite sensitive actually in effusions or in cardiac tamponade, but not the most specific. As you know, a lot of things that cause dilated IVC, particularly in our cardiac patients. If you are unable to really visualize it, then something that's been suggested is looking at the hepatic veins, and if there's this tension there, that's also quite suggestive. And then if you run an M mode, then you're able to see here, sort of the respiratory variability here. It's about 25% with a dilated IVC, so it's suggestive. But an important caveat to this is it could be absent in so-called low pressure cardiac tamponade. So let's say you've got a sort of chronically growing effusion for which it's compensated, and acutely you become hypovolemic, and so let's say you from a gastroenteral illness or acute bleeding or that sort of thing, then you still have low chamber pressures, but then you're able to sort of still get tamponade physiology and chamber collapse. Are there any numbers for dilated hepatic veins? So I haven't found anything with regards to that, at least certainly from the American Society of Echocardiography. So maybe one of the staff might be able to say anything. I'm getting some no's here from Dr.
Visual illustration.
Big is big.
Yeah, so I guess it's more of a visual. So
I can wait to see it.
You just know. Okay. So yeah, basically, that low pressure tamponade, don't be fooled. Thankfully, it's a fairly rare occasion. And then localized effusions, if you've got a post-surgical effusion, that may be exerting localized tamponade, let's say to the left ventricular side without getting any sort of the right heart sort of findings. And so don't be fooled necessarily if you've got a high clinical suspicion. Okay, moving on to sort of more Doppler assessments now. So you've got looking at mitral and tricuspid inflow. So really what this is pointing to is sort of the sonographic evidence of increased ventricular interdependence. And so when you look through the valves, basically as we mentioned, if you get inspiration, you get decreased amount of cardiac output. And so if you're looking through the mitral valve and you're looking at peak E wave velocity, it will actually drop during cardiac tamponade. And that drop, really, studies have shown that it has to be at least 25% if you're going to start evoking cardiac tamponade physiology, because there is some variability, as I mentioned. For the tricuspid valve, because there's more variability at baseline under physiological circumstances, we're looking at more than 40% now. And it's expiratory reduction, because as I mentioned, when you take a breath in, you actually increase the amount of flow. And so that's sort of shown here on this little pictogram here. And then, this is basically as you take a breath, you're losing that and you're looking for 25% drop, then here 40% expiratory drop. And that's sort of the cycle. And we'll talk about the VTI a little bit as well, because you can run it across all the valves. So this is a pressure wave Doppler representation. On the left, you've got the mitral valve, on the right, the tricuspid. And so you do have to change your sweep speed to be able to better appreciate it. But if you've got, the respiratory variability here, so you see on inspiration, quite significant drop here. And this is, more than 25%. And then if you do the pressure wave, the pressure Doppler across tricuspid, on expiration, you're going to lose a lot more than 40% here. And so this points to increased ventricular interdependence, but it's not the most specific. If you run it, again, the Doppler across the aortic and pulmonic valves, I can convince you that it's probably going to be the same findings. And then certainly the LV and RV outflow tracts are not exempt from this physiology as well. What we're looking at here in terms of the guidelines, they're talking about now a more than 10% drop in the peak LVOT velocity, and then similar, but an increase in the RVOT side. So I've shown here sort of across the aortic valve what that might look like. And so again, as you take a breath, inspiration, you're getting that drop, which is here more than 10%. And then really interestingly, this is really the sonographic equivalent of pulses. So as you lose amount of cardiac output stroke volume, that's what you sort of is manifested in clinically with a drop in blood pressure. So that's quite neat to be able to see that. So next, looking at hepatic vein flow in tamponade. So there's certainly as well respiratory variability if you're running the Doppler through the hepatic vein. So the biggest thing as you get, systole, you get forward flow, and then as you get, you take a breath, that flow is accentuated as we know because of the fact that you get increased venous return. But interestingly, on expiration, because of the fact that now you've got those sort of right chamber filling problems, then you get basically an attenuation of diastolic flow, and you can even get flow reversal, which is sort of manifested here. And that's actually quite good based on the study that I've seen. It's very strong test characteristics for predicting cardiac tamponade with sensitivities that I've seen up in the high 80s. So pretty good predictive value, but unfortunately it's quite difficult to assess, I think, in up to 1/3 of patients. So if you see it, it's quite useful, but it may not be present every time, or it may be difficult to assess. So let's talk about the caveats and limitations of this, because I think, I think any modality has limitations. So when we talk about chamber collapse, that's assuming that you have normal filling pressures at baseline. So right heart diastolic collapse may occur only at very high levels of pericardial pressures in states like RVH, severe pulmonary hypertension, severe LV dysfunction. That's always something to consider, when you look at the patient as a whole. Collapse, the corollary of that is that collapse can occur earlier if you've got hypovolemic states. And so, we talked about kind of low pressure cardiac tamponade as well. IVC plethora may be absent in low pressure states of loculated effusions. I kind of talked a bit about that. And then importantly, posterior loculated effusions, particularly in the context of bolus cardiac surgery or trauma, they can also produce sort of left-sided diastolic collapse. I didn't really show pictures because it's thankfully not that common because of the virtue of the fact that we're higher pressure states, but that's something to consider. And unfortunately, that regional tamponade may be more difficult to assess on transthoracic echo. So you may need to do other modalities, transesophageal or other things like scans, CT scans to assess for that. And then the last point here, the sonographic features of increased ventricular interdependence. So, the respiratory variability across the valves that I talked about, they can be present without tamponade. If you've got increased big swings in pressures, COPD, PEs can do it. So it's not, again, the most specific. And then it can be absent with features of cardiac tamponade. If you've got an ASD with shunting, severe ARs, the LV is more expanded, and then things like positive pressure ventilation in mechanically ventilated patients. So just understanding the limitations of what we do are important. So next, looking at echo in pericardiocentesis and how that sort of evolved. So again, a little bit of history. So in 1653 is the earliest I've seen sort of Jean Rioland, which was a French surgeon. He suggested that, pericardial fluid may compress the heart, and that sort of proposition is that trephining the sternum, so that's really putting a hole through the sternum, might be a means to relieve that pressure. So thankfully, we've kind of evolved from that, so we don't have to do that. In 1840, that was the first blind pericardiocentesis. That was by an Austrian physician, Franz Schuh, via the left peristernal approach. And then it took until 1911 when Antoine Marfan introduced the subxiphoid approach, which actually was the most common approach for a while, despite here 50% morbidity, 60% mortality. And we still do blind pericardiocentesis if needed, if the patient's very unstable. But thankfully now with the advent of echo, we're able to do that. And then this is another little interesting tidbit that in 1964, the first diagnostic use of echo was really to assess pericardial effusions. And so still very relevant today.
And then since the late 70s, really echo-guided percutaneous pericardiocentesis is the preferred method. So that's another useful role for that. So here are the approaches to echo-guided pericardiocentesis. So the main approaches are apical, windows, and peristernal subxiphoid. Is what I've seen the most, and each they have their unique benefits and risks. And so when you're assessing the patient, looking at all those views, making sure you characterize them very well, it's important to see which one might be the most amenable. And generally, from what I've seen in terms of recommendations, there isn't anything very fixed, but they say that the most appropriate for selection is the one where the fluid is closest to the body surface and in which intervening vital structures are least likely to be damaged, which makes sense, sort of intuitive. So looking at each of the different approaches, the different landmarks right here under the xiphoid process next to the sort of subcostal window. The risk here is that you've got liver in the way, and so that can cause bleeding. But thankfully, it's a lower risk of pneumothorax, so these are some of the competing risks and benefits. Then you go peristernal, here the landmark, it's a little bit more on the fifth intercostal space, and what you want to go is really less than a centimeter to the left, because then you've got the lima, you don't want to damage that structure. So that's another sort of downside, if you will, of going by that peristernal long. And you also have a risk of pneumothorax as well. And then the apical view, which I personally very much like, is sort of one of the advantages that the heart, you're getting into the maximum point of maximal impulse, and so it's quite close to the wall, and so that allows you to sort of limit the amount of risk of perforating other structures. Still, there's a risk of pneumothorax, but there's also a risk of perforating the LV. But thankfully, the LV is a high pressure sort of system, so if you don't dilate once you're in the LV, then at least it will sort of tamponade by itself, hopefully. So these are some of the things. So here, I'm just going to go back. So basically, that's one of the biggest roles of echo. But then echo, once you do the procedure, so just for those who aren't as familiar with it, so you're basically inserting a needle, and then you advance a wire through that, assuming once you get return, you're in the space. And so that guide wire, then you can put a sort of small catheter over it. And then how do we confirm? Well, we can inject agitated saline to see where that fluid goes, and sort of in real time. So echo allows us also to confirm where we are in the pericardial space. And so looking here, this is sort of on the left-hand side, an apical approach here. So I think you can sort of all get a sense of appreciate that, these sort of bubbles are sort of entering the pericardial space at the LV-RV. And so this is a good sign. This is what you kind of want to see, and it's a very satisfying feeling when you get it, that you are in the right space, and that so now you can safely sort of dilate and introduce a larger catheter to be able to drain that fluid safely. So that's quite nice. Let me just get my cursor. This is on the right-hand side, a different outcome. So if we just look here, I think we can sort of appreciate that the bubbles are not where you want them to be, and so here in the left ventricle. So probably a better approach is to withdraw the needle and try again. And so this is another important use of echo in pericardiocentesis. So a few takeaway points here, and then I'll just open the floor for discussion. Although cardiac tamponade is a clinical diagnosis, echo is still a valuable tool, and I think it's important that every patient should warrant that to assess for altered hemodynamic physiology, because they may find features that are kind of early in that spectrum of what we mentioned as a heterogeneous disease. The size of the effusion needed to create the tamponade physiology really depends on the speed of onset, so don't be fooled by a smaller effusion where you may still get hemodynamic compromise. The absence of any chamber collapse seems to be a pretty good echocardiographic feature with the greatest negative predictive value to rule out tamponade. So if you've got no chamber collapse, that seems to be, in the study that's seen, pretty good at ruling out almost tamponade. Obviously, there's, we talked about kind of low pressure tamponade as a possible thing as well. IVC plethora is very sensitive and carries a high negative predictive value, but again, beware of its sort of pitfalls. And there's significant respiratory variation across the mitral and tricuspid valve should not be used alone as a standalone criteria for tamponade without the presence of chamber collapse, IVC dilation, abnormal hepatic vein flows, because as we mentioned, it's not the most specific. There can be increased ventricular interdependence in other states. And then obviously the final decision and management of the effusions should always be made with a detailed physical exam, proper clinical assessments, but echo is quite useful. These are the references I have, and I'm happy to open the floor for discussions.